is Dr. Melena Bellin, who is an associate professor in the Department of Pediatrics with a specialization in endocrinology. And she's been, Melena's been one of our leaders in unraveling and characterizing the relationship of diabetes and the exocrine pancreas. So we're, thank you, Melena, for taking the time to be here with us.
Thank you. Am I allowed to touch this laptop to advance the slides? It's a big note on it that says, please do not touch this laptop. It's on here 3 places.
It's only in 3 different places.
Yeah, thank you. I'm going to shift gears a bit here from our sessions this morning and actually talk more specifically about diabetes as it pertains to pancreatic disease. I have some disclosures not particularly relevant to this talk today. So I'm going to talk a little bit about how we define pancreatogenic diabetes, and I'll say in advance here, I'm really going to focus on chronic pancreatitis. This is kind of a pretty big encompassing category that includes chronic pancreatitis, pancreatic cancer, and in the interest of having only 20 minutes, I'm going to be fairly focused here in chronic pancreatitis-related diabetes and the pathophysiology of that, and elements related to how these patients should be screened and managed, at least based on the, I'd say, very limited data we have specifically for this population. So I think the terminology is actually really confusing here for providers, for patients, for endocrinologists, for everyone. I think that has a lot to do with the focus in diabetes, and the diabetes world is type 1 diabetes, type 2 diabetes. So people don't really give a lot of attention to other forms of diabetes other than type 1 and type 2. So I constantly have patients coming in saying, what form of diabetes do I have? And there's different terms that I think have been variably applied to this form of diabetes. So if we're talking about pancreatogenic diabetes, it's also been called pancreatic diabetes. Type 3C diabetes is also a popular term for this. This is probably, I'd say honestly, more recognized in the GI community than the endocrine community, but it does sort of evolve from a table that used to appear in the American Diabetes Association on classifications of forms of diabetes. And bullet point 1 was type 1, bullet point 2 was type 2, and bullet point 3 had some subtypes, of which 3C was the pancreatogenic diabetes. So that's how that evolved. But all of these are referring to the same thing. They're basically referring to a class of diabetes that is due to where the primary problem is an exocrine pancreatic disease. So how common is this? And the answer is we don't have a great answer for that too. The estimates would probably be between about 1 to 9% of diabetes is type 3C or pancreatogenic diabetes. The 9% estimate is the one study that I think actually looked at a large series of patients who were diagnosed with diabetes, who came into a tertiary care center in Germany, where they actually reviewed their medical history, imaging studies, et cetera, that were available, sort of reclassified patients regardless of how they were initially classified as type 1, type 2, type 3C. Now, the problem herein is that was a tertiary care center, so it probably has a little bit of a selection bias and an overestimate. So the true prevalence is probably somewhat less than that 9%. But what are our challenges here? Well, say at least in the US here, the coding schema is a big challenge because the ICD-10 codes largely recognize type 1 and type 2. In fact, sometimes if I'm submitting something to the insurance, I want to get test strips, medications, pump supplies covered. Particularly for pump supplies, they need a type 1 diabetes code, for instance. And so sometimes those ICD-10 codes get applied for type 1 or type 2 to this population because that's what exists and that's what we use. So that gets very confusing. There may be patients who have some chronic abdominal pain, they present with diabetes, they have undiagnosed chronic pancreatitis. And then there are people who have chronic pancreatitis, they get diabetes, they go into an endocrinologist, or maybe a primary care provider, but it's the distinction between that being related to the diabetes or type 1 or type 2 isn't always clear. So they may just be called type 1 or type 2, when in fact they also have pancreatitis. So I told you I'm going to focus on the pancreatitis piece, but this is kind of a broad inclusive category. So typically when people are talking about type 3C or pancreatogenic diabetes, they're talking about chronic pancreatitis or even acute pancreatitis, as we're not figuring out, pancreatic cancer, pancreatic resection. So certainly this is a big thing I deal with in the whole pancreatectomy islet autotransplant world, and they have some similarities with general chronic pancreatitis. Cystic fibrosis related diabetes. I'm not going to get into that. That shares some similarities, I think, in pathophysiology to chronic pancreatitis, but cystic fibrosis, at least with classic lung disease, carries some considerations for treatment in terms of the impact of insulin treatment on lung health and survival, and then other exocrine pancreas diseases. So we talked a lot about pain today, and endoscopic therapy and surgical therapy. And of course, the clinical hallmark, the really distressing symptom, I think, for most patients of pancreatitis is the pain. And that's probably multifactorial, related to scarring, obstruction, ischemia. But while all that's going on, we think what's happening is over time, there's chronic damage, scarring within the pancreas, chronic inflammation, and all of that is contributing to beta cell failure. So for patients, I'm going to flip the prevalence question. So for patients who have chronic pancreatitis, how common is it for someone who has chronic pancreatitis to actually have diabetes? And it really depends on what patient population you're looking at. What seems to be fairly consistent is if you look at most series of patients with chronic pancreatitis, particularly in the adult literature, the people who usually have kind of longer duration disease, somewhere between 1/4 to 3/4 of those patients will typically have diabetes or at least some impaired glucose tolerance. So certainly having some endocrine dysfunction in the face of chronic pancreatitis is really, really common. So why does it vary? Well, it probably depends on what patient population you're looking at, because we know factors like how long you've had disease, do you have calcifications in your pancreas, what type of disease you have. Hereditary pancreatitis like PRSS1 has a fairly high lifetime risk for diabetes. And not on here, I probably should have added a slide here, but I left it out in the sake of time. Things that actually are conventional, say type 2 diabetes risk factors, like obesity and positive family history of diabetes, also convey some risk in this population. So the answer is it kind of depends on who you're looking at, but it's common, and it's something we should be thinking of in patients we see with pancreatitis. So why does it happen? I think that the hallmark of chronic pancreatitis related diabetes is still insulin deficiency. And the very classic thought process behind this is that patients who have chronic pancreatitis because of chronic damage have irreversible beta cell loss. So they've reduced beta cell mass in chronic pancreatitis. The fibrosis is actually targeting the exocrine pancreas, but it actually just sort of as a bystander injury scars over the endocrine pancreas, and so there's islet injury and loss. There's actually pathology studies that show this. So this graphics that I'm showing you here from about 9 years ago from a pathology study that looked at patients specifically with chronic pancreatitis. On one hand, who had clinical diabetes diagnosis or not, and it's the upper graph there, and the lower graph is actually based on patients who had lab studies, whether they had normal fasting glucose, impaired fasting glucose, and diabetes. And what you're seeing there is the fractional beta cell area on the y-axis, and you can see, I think, very clearly that as you go from non-diabetic to diabetic, or normal glucose tolerance to impaired to diabetic, that you're losing beta cell mass along that spectrum in that patient population. So we can see this. Obviously, we can't do pathology studies on people who are walking around living with chronic pancreatitis, but we can actually see this reflected on in vitro or in vivo testing. So doing stimulatory tests like mixed meal tolerance tests or IV stimuli like glucose and arginine. There are a series that show that patients with chronic pancreatitis and exocrine insufficiency or chronic pancreatitis and diabetes have reduced C-peptide and insulin secretion on those stimulatory tests. So we see this reflected in our patients, not just the pathology studies. And then people who have looked at exocrine insufficiency and endocrine insufficiency, probably not surprisingly, I think, there's a correlation between endocrine and exocrine insufficiency. So exocrine insufficiency is one of the risk factors that's associated with a higher risk of diabetes. And if you think about it, exocrine insufficiency is probably happening for the same reason, right? You're getting fibrosis, you're getting loss of acinar tissue, therefore you're becoming exocrine insufficient at the same time that's damaging islet tissue. I think as you heard from Fred Gorelick earlier in the morning, our pancreas actually has a fairly nice reserve in terms of what we can lose before we become diabetic, and so, or have exocrine insufficiency. So he actually referred to needing to lose about 90% of the pancreas function to be exocrine insufficient. And that would have been kind of the old estimate for diabetes. You need to lose about 90%. It probably depends on how heavy people are, and maybe more recent estimates would say you have to lose about 50 to 75% of your islet mass before you actually manifest with clinical glucose abnormalities. So I think that's a good thing for people with pancreatitis. They have some scarring, but it does make it difficult to assess perhaps where people are in the progression to diabetes. So what's the more recent data? It's probably not just all about permanent islet loss. There's some more recent data that suggests that chronic pancreatic inflammation actually can induce beta cell dysfunction. So in addition to having poor insulin secretion from permanent beta cell loss, there's probably just a dysfunction that's happening even earlier on from the inflammation. And so this table here is from a series of again, pancreatic tissue from patients who have no chronic pancreatitis and then patients who have chronic pancreatitis with or without diabetes. And for the patients with chronic pancreatitis and the controls, they're looking at intrapancreatic cytokine profiles. And in the diabetic patients in particular, there's a huge elevation, very marked elevation of intrapancreatic cytokines. In particular, the pancreatic cytokine INF-gamma has been associated with dysfunction of the beta cells and may induce some risk of diabetes. So there's an inflammatory milieu and an islet loss that are contributing to this insulin deficiency. So it turns out there is a little bit more than just insulin deficiency. I think insulin deficiency is where we have the best data, but there's probably some changes in insulin sensitivity. Probably the best hypothesized or documented of that is a hepatic insulin resistance. Now, there are ways that we can actually measure in people by infusing glucose and insulin at the same time and measuring how the body processes that. We can measure insulin sensitivity. We can get specifically at hepatic insulin sensitivity by doing glucose tracers. It's very involved. It's a very difficult study to do. So this has been done on a very limited number of patients with chronic pancreatitis. But the small studies we have that are mostly men, mostly alcoholic pancreatitis, done a number of years ago, do suggest that in this patient population, there's a hepatic insulin resistance. And the whole body kind of peripheral insulin sensitivity data is a little bit mixed. So there may be some other alterations in insulin sensitivity. The patients who have very advanced islet loss may have glucagon deficiency, but actually there's a crosstalk between the beta cells and the alpha cells. So earlier on in the disease course, you actually lose a normal suppression of glucagon when you drink a meal or eat a meal or drink an oral glucose tolerance test. And so that can exacerbate endogenous glucose production from the liver. So you're not kind of shutting off your own stores appropriately when you eat. And then these patients who have malabsorption may have some abnormalities in the incretin hormone axis. The data's been a little bit mixed there, but what's probably been clearest is if you put someone on pancreatic enzyme therapy who has chronic pancreatitis or cystic fibrosis, their incretin hormone response to GLP-1 and GIP from the gut improve. So what do we do with these patients who have chronic pancreatitis who may or may not have diabetes? And my first caveat is we have no clinical trial data in this population. So everything I'm going to say is basically expert consensus and is extrapolated from what we know about type 1 and type 2 diabetes. So there's a set of expert consensus guidelines that came out with Dr. Mike Rickles at UPenn, kind of heading up this effort at the Pancreas Fest meeting a number of years ago. I think what is probably most common sense and clear is we should be screening patients who have chronic pancreatitis for diabetes. We know they're at high risk, and that probably the most logical way to do that is the way we screen everyone else who's at risk for diabetes, like type 1 or type 2 diabetes, particularly for people who are obese. You may do this in clinical practice. So once yearly for patients who have chronic pancreatitis, we recommend that at minimum, they get a hemoglobin A1C level and a fasting plasma glucose. The hemoglobin A1C level is particularly easy because they can show up in your clinic any time of the day and you can still do that. The fasting has to be a little bit more planned. If there is some impairment, but it doesn't reach the diabetes threshold, so impaired fasting glucose, pre-diabetic A1C level, then really consider an oral glucose tolerance test or a more sophisticated kind of test to get at impaired glucose tolerance or early diabetes. And then they're diagnosed by the same American Diabetes Association criteria that we use for other forms of diabetes. So fasting plasma glucose, 126 or higher, A1C, 6.5% or higher, or a random glucose of greater than 200 with symptoms. And unless they're clearly symptomatic and you have that high random glucose, you really should confirm that on a second occasion. So again, there are no treatment studies specifically for chronic pancreatitis and diabetes. So we have largely used pathophysiology in trying to figure out what to recommend for treatment of diabetes in this population. And so these are kind of the same things that I talked about in the previous slides, but because insulin deficiency is a big part of the problem in chronic pancreatitis, insulin therapy is a common approach. Talked about alterations in insulin sensitivity. One of the medications on the market that can address hepatic insulin sensitivity is metformin. So metformin has been another mainstay I think one thing that I actually try to really consider as an endocrinologist, but I think sometimes gets missed, and my patients say who come back after total pancreatectomy, is the malabsorption component. And so this population of patients with chronic pancreatitis, obviously, as you heard, they're high risk for exocrine insufficiency, malabsorption. When you're trying to treat diabetes, particularly for someone who's on insulin therapy, you're trying to match up the medications you're getting to what their body's doing. So if you have someone who is sometimes absorbing their food, sometimes not, you really can't predict what they're getting based on their oral intake. You need to be addressing that exocrine insufficiency to have the most consistent response to your diabetes therapy. So that's actually an important part of diabetes management in this setting. This is a population that has some increased risk for pancreatic cancer, particularly depending on the etiology, like they have a genetic mutation, and co-risk factors like smoking. And that comes into play in sort of consideration of metformin. I'll talk about that in a minute. The other thing I want to highlight here is that there's at least an anecdotal thought that there's an increased risk of hypoglycemia in this population. We seem to see some of these patients being more susceptible to hypoglycemia, particularly on the insulin therapy. I would say that the objective data for that is more lacking, largely because those studies haven't really been done. I mean, I think with continuous glucose monitoring technology, it would be feasible to really actually study that in better detail. I think we just kind of lack the data on what that hypoglycemia risk is. But if it's there, it's proposed to be because they may have this glucagon deficiency, as the alpha cells are very significantly destroyed. And then also this perhaps enhanced insulin sensitivity of the malabsorption component. So the first line treatments for chronic pancreatitis diabetes, first of all, insulin therapy. Many of these patients will go on to need insulin therapy because they are insulin deficient. You're addressing a primary defect in the pathophysiology. There are some drawbacks, obviously, to insulin therapy. Insulin therapy of all our therapies has the biggest hypoglycemia risk. So you're dealing with low glucose risk there. It is an injection. We don't have any way to give insulin other than injections or pumps, which is still a form of subcutaneous therapy. So obviously there are some patients who don't really want to go on an injection. So that's a consideration. And we don't really know what the approach should be. So do we use basal insulin? Do we use bolus insulin? Usually basal insulin analogs are probably used first just because they're easy. So the other consideration is metformin. Metformin is really safe and pretty well tolerated, except for the GI side effects, which I admit can be kind of a strain in this population sometimes. But for the most part, it's a pretty safe drug. For those patients who have a big insulin resistance component, hepatic insulin sensitivity impairment component, it really may be beneficial. And this is where we get into this theoretic potential protective effect of metformin based on some epidemiologic data against pancreatic cancer. And then obviously make sure you're treating any exocrine insufficiency. So you want to make sure that's getting diagnosed, they're getting screened for exocrine insufficiency, it's getting properly managed so that they can have a normal incretin hormone response and that they don't have this malabsorption component that's going on if they're taking insulin therapy. So just want to show this recent data that came out of diabetes care, one of the few diabetes care manuscripts that actually focused on pancreatitis. And it was out of a very large series in the UK, basically a population series looking at insulin use in type 2 diabetics versus those with chronic pancreatitis or acute pancreatitis who subsequently developed diabetes. I think it just highlights here how frequently insulin is needed in this population, a much higher rate of insulin use than conventional type 2 diabetes, for the reason why I think it's important too to get to the right diagnosis. So what about the metformin and that question of cancer risk? Well, I'll say that I think the jury is kind of out on this, but there's some epidemiologic evidence, including case control studies in patients who have type 2 diabetes, different form of diabetes where insulin levels are often high, that treating with metformin reduces the odds of developing pancreatic cancer. There's some more recent meta-analyses in people who have pancreatic cancer, suggesting that people who are on metformin may have a longer survival. I'm not aware of any actual direct clinical trials that have done in this, however. So it's really observational. The proposed mechanisms have to do with inhibiting certain cancer signaling pathways that might be important. So what about other antihyperglycemic medications? Just to wrap up and not forget to mention these, we have very little data on other medications. The two that probably you have to think about most in terms of having caution with them is the GLP-1 analogs or DPP-4 inhibitors in particular, just because of this theoretic association with pancreatic cancer and pancreatitis. And then a very new on the market, the SGLT2 inhibitors, which are like the Invicanas. In that class, there is a risk of euglycemic diabetic ketoacidosis in this population, so you have to consider that. Probably the big debate that's happened in the last 10 years in the GI and diabetes community is, are these GLP-1 analog therapies actually associated with pancreatitis and pancreatic cancer? There were some animal studies, pathology studies that suggested that they might be. That evidence has really been controversial, I would say the least. And if you look at people with type 2 diabetes, I think the more recent evidence is suggesting in routine type 2 diabetes, GLP-1 analogs are safe for the most part, don't increase pancreatitis risk, don't increase pancreatic cancer risk. But my big caveat would be that they have not been used in people who haven't been studied, I should say, in people who have pancreatitis. I just want to mention that very last year, I had one case experience with this, and it was a gentleman who had an attempted total pancreatectomy islet autotransplant with us, but he had very severe disease. So his pancreatic head was left in place. And fortunately, he actually got pretty good pain relief despite still having a pancreatic head left in place. But his big struggle is obesity. He continued to gain weight after the procedure. And so he was following with weight management clinic, who had tried a whole bunch of strategies. And finally, at 3 years post-op, they offered him liraglutide, which is a GLP-1 analog, a long-acting one. And they did counsel him. I'm not sure he fully understood what he was getting into, but he accepted the risk, went on it. I saw him about a couple months later, hadn't known he had started it, but found out in clinic visit, started asking about symptoms. He was having new pancreatitis symptoms, contacted the weight management clinic. They obtained a CT, he had acute pancreatitis. We stopped liraglutide. Unfortunately, he kept perpetually having acute pancreatitis after that. After being well for 3 years, he went back on opioids. He had some suicidal thoughts. He finally got a spinal cord stimulator, and that's actually doing well with that, but it was quite an ordeal. And it's really put me in a very cautious state about ever thinking about this type of medication with someone who has pancreatitis if you can, use something else. So here's kind of the working algorithm I would use right now with our current data for screening and treatment of type 1 or type 3C diabetes. So make sure the patients with chronic pancreatitis who have not been diagnosed with diabetes are being screened annually with A1C, fasting plasma glucose. If they're not diabetic, then you're screening every year and just continue to follow them. If you diagnose new diabetes, think about insulin with or without metformin, or metformin alone. And my threshold is kind of how hyperglycemic are they? Are they overweight? So someone who has mild hyperglycemia, particularly if they're obese, if they seem to have other type 2 diabetes features, I think metformin's a very appropriate first line in that population. Someone who's very hyperglycemic, very thin, very malnourished is probably going to benefit more, honestly, from insulin therapy. So I think it's a little bit on a case-by-case patient basis. Remember the nutritional aspects. Make sure to think about pancreatic enzyme replacement. Oh, thank you.